Kia ora. Thank you so much for joining us this evening. It's great to have you here for what we know will be an insightful and valuable session. My name is Lydia and I'm the CEO at Fertility New Zealand. We're a national charity dedicated to providing support and information services and advocating for all people facing fertility challenges. Whether you're just beginning to think about your fertility, undergoing treatment, or exploring alternative pathways to parenthood, Fertility New Zealand is here to support you with trustworthy information, community, and care. As a charity, we rely on the generosity of our community to make resources like tonight's webinar possible. If you find value in what we offer, please make a donation. You can do this via a link that will appear shortly, or on our website, fertilitynz.org.nz. Every contribution helps us continue our mission and reach more people in need of support. Tonight's topic is one that deserves far more attention than it often gets: male factor infertility. It is estimated that male factors contribute to up to 50% of all fertility cases, yet it's an area that is still surrounded by uncertainty and often overlooked in conversations about fertility. That's why we're incredibly fortunate to be joined tonight by Dr. Amir Zarrabi, who brings a wealth of experience, compassion, and knowledge to this important subject. Dr. Zarrabi is an Associate Professor of Urology with a PhD in male factor and male fertility, and microsurgery. He's a highly respected consultant at Repromed here in New Zealand, and he's helped many individuals and couples navigate the often complex journey of male infertility with evidence-based and personalised care. During this session, Dr. Zarrabi will walk us through what male factor infertility is and how it may affect your fertility journey, the role of sperm health and lifestyle changes that can make a meaningful difference, when and why you might consider a sperm donor. We'll wrap up the evening with a live Q&A, so please type your questions into the chat at any time and we'll aim to answer as many as we can at the end. Thanks again for joining us. We're so glad you're here. And now I'm pleased to hand over to Dr. Amir Zarrabi.
Thank you very much, Lydia. It's absolutely wonderful to join you guys this evening, and thanks for everyone who tuned in. This topic is really close to my heart. This has been the passion for me in my career over the last more than almost 15 years. And a little bit of background: I qualified in South Africa as a doctor about 25 years ago, and as a urologist in 2009. I worked in South Africa for 10 years and then moved to New Zealand, accepting an academic position at the University of Otago in 2019. I specialize in male infertility and microsurgery, and I think probably the highlight of my career was let me just get the slides. Yeah, there we go. I was part of the surgical team that performed the first successful penis transplant in the world about 8 or 9 years ago. We subsequently did another one of those, and that was obviously big news. So to get to today's talk, I'm going to take about 25-30 minutes, and I've tried to keep this really relevant and interesting. And these are the topics we're going to cover. Firstly, that male fertility is actually very common, much more common than people realize. How to quickly find out if there is a problem. Then we will cover practical things, the common causes for male infertility and the treatment options that we have, the role of microsurgery, and then just something about the bigger picture. So I think firstly, men tend to not talk a lot about being infertile or subfertile or having a low or a poor sperm count. But we know from research that, and this is a recent publication by the BBC, that sperm counts have basically halved over the last 50 years. If you look at 1973 to 2018, the average sperm count of the average man has gone down from 104 to 49 million per milliliter. And this is significant. Why? We think it's the environment, the stuff that we inhale, the stuff that we eat, the stuff that's in the food, but also our lifestyles don't help. So what? There's still more than enough sperm, I guess. 49 million is heaps. Apart from the future of humanity, we know now from research done in the last 10 years that infertile or subfertile males actually have poorer health outcomes than their counterparts with normal fertility. So it is an independent risk factor. And I think the relevance of that is that if you are a man with a low or abnormal sperm count, you are at risk of having other health conditions, which, if going undiagnosed, may have consequences later down the line. All right, so let's get right into it. How to quickly find out if there is a male fertility problem. Now, if you as a couple are struggling to conceive, most people still think it's a female problem. We know that in half of the cases, a male factor plays a role. And one of my main messages tonight is to not wait too long before seeking help. Couples are trying to get pregnant at later points in their lives, at more advanced ages, maybe mid-30s. And if you then find there's a problem, then time becomes really critical. So step one is to, when you are struggling to get pregnant, to actually consider that a male factor may play a role. Step two is, when you go to your GP or your doctor, ask for a sperm analysis to be done early on. A sperm analysis in New Zealand is free for most people. The basic analysis can be done at the normal pathology lab with a form from your GP, and it will quickly show if there is a problem. So there are these cut-off values. This is the previous edition of the World Health Organization, and it's not a perfect tool, and there's a lot of interpretation that goes into reading those results, but it gives us a good idea of what we're dealing with. If your sperm count is lower than 50 million, then we should be, your concentration, we should be looking at causes. So this is the sperm analysis, and the results will look something like that. Step three, if there are abnormalities on the sperm test, then make sure you see a male fertility specialist. You should either ask your GP to refer you, or you should check online. To just see a fertility specialist is not always adequate. Not all fertility doctors specialize in male fertility. It has become worldwide a very specialized field. And I think in order to be sure that you are receiving all the options, it is important to make sure you are dealing with a doctor that knows about the factors affecting males. So what can you expect from your fertility doctor? For a male, they will at least take a full history. So looking at your lifestyle, previous surgery, illnesses, trauma. They will do a clinical examination of the testicle. The testicular size is actually a very, very accurate indicator of what's going on function-wise. They will look for a varicocele, which we will discuss, and then see if the vas deferens, which is the tube that transports the sperm, is actually palpable. And they will do some blood tests. And it's basic, simple hormone levels, once again, free of charge, done at the normal pathology lab. And once, for me in any case, once I have a history, an examination, and those blood tests, I can usually pinpoint where the problem lies. And I want to say there are many treatable causes of male infertility. And I have seen this so many times where when we give treatment and we correct the problem, couples can go on to have a baby the normal way without expensive and invasive fertility treatments. But that being said, in not all cases is this possible. So we sometimes are faced with a situation where we make a diagnosis, but perhaps there are no treatment options or treatment is not successful. And it's good to know that we have assisted reproductive technologies, ART, fertility treatments, IVF, ICSI available. So I think it is really about combining all of the options that we have to get to the most effective and successful for each of the patients. All right, now I'm going to go on to the causes, the most common causes of male infertility now, and I am specifically trying to keep it really basic at a level that makes it very clear. A varicocele is the first one. Now, a varicocele is basically a varicose vein on the testicle. It's a big vein that sits on top of the testicle. These veins are bad because they are filled with warm blood that comes from your core, and they heat up the scrotum. Your testicles hang outside the body because they are supposed to be at about 2 degrees Celsius lower than body temperature to function optimally. If you have all of this warm blood surrounding the testicle, it causes what we call heat stress, which profoundly affects the function of the testicle. So varicoceles are one of the more common causes of having a poor sperm count, poor sperm movement, low counts. 15% of adult males have a varicocele, but not all of them does it affect their fertility. We don't know why, but some men's testicles are resilient and are not affected by this, and others are profoundly affected. So it can cause shrinkage of the testicle, especially on the side of the varicocele where the testicle will actually decrease in size. It can affect many aspects of the sperm movement, what they look like, the number of sperm, the DNA quality in the sperm. And there is evidence that the negative effect on sperm is progressive. In other words, the longer the varicocele stays there, the more it affects the function of the testicle. Fixing this varicocele is a relatively easy and simple way of improving or fixing the fertility problem. And I often tell men that if you get diagnosed with a varicocele as the cause of your infertility, it's probably the best diagnosis you can get because it's one of the most treatable conditions. We do a surgery where we don't strip those veins out like they do for leg varicose veins. We tie all these veins off with a surgical microscope and stop this warm blood from entering the testicle or from accumulating around the testicle. And it's an immediate fix. We know that a cycle of sperm production takes about 76 days. So within 3 months, we will see the effects of removing the varicocele on the sperm. There are various ways of fixing a varicocele. We want a treatment which has a high success rate. We want a treatment with a low complication rate, and we want to have the best improvement in sperm quality that we can get. And there's been a lot of research about this. The bottom line is that the microsurgical method has been shown to have the highest pregnancy rates, the lowest recurrence rate, and the lowest complication rate. Now, it all sounds great, and it is, but in about 20 to 25% of men, even fixing the varicocele does not change the fertility parameters, other sperm parameters. It does not improve the sperm quality. We think it is those cases where the damage sustained by the testicle over the many years that the varicocele had been present was just too severe, and the testicle simply does not recover. But that we will know 3 months after the operation. And that's what I tell patients is, we've got a good chance of improving your sperm count. We've got a good chance of making a normal pregnancy possible, but we cannot, unfortunately, guarantee it. About 75% of men will have that outcome. So that, I think I've covered most of this. Why do we treat the varicocele? And this is based on medical publications. You get improvements in the sperm parameters. Oxidative stress is reduced. We'll talk a bit about this later on. The DNA quality in the sperm is improved. Natural pregnancy rates are increased. We talked about the microsurgical technique and the fact that we will know the outcome 3 months afterwards. I actually did 2 of these operations today on men. Not all men with varicoceles have fertility problems. That's a common cause of pain in the testicles. And
Can you hear us, Amir? Hi, Amir. Can you hear us here? We can't hear you. Your sound's gone. Sorry, guys. We're just having some technical issues here at the moment. No, can't hear you. Sorry about this, everybody.
can you hear me now?
Yes, perfect. Thank you.
Sorry about that. Do I need to repeat something? Where did you lose me? Okay, I'll just continue. We will talk about lifestyle factors next, which are really important, and I consider them easy wins. On my graph there are the energy drinks containing caffeine. I myself like my coffee. If you look at the last bullet point, these are all the factors that can affect sperm quality. Caffeine can, but you need to drink a lot of it. So 1 espresso shot is about 60 to 80 milligrams, and only if you take more than 270 milligrams a day does it affect the sperm quality. Lots of research about the other lifestyle factors. Definitely smoking can affect it. Alcohol, we know that alcohol binges are more detrimental to sperm health than more moderate regular consumption. So if you want to have 1 drink a day or 1 or 2, that's probably better than having 10 drinks over the weekend. Being overweight is not good. Drugs, then occupational toxin exposure, which is not that common. Very interesting. The older a man gets, the more the sperm quality can be affected, and that actually starts even as young as 34 years of age. Cycling, men often ask me, is that the cause, or should I do less cycling? And the answer is no. the evidence shows that unless you are a pro cyclist that spends about 6 hours on your bike a day, the cardiovascular benefits of cycling are way more than any effect on sperm. Heat stress. So we talked about heat stress and varicocele, but obesity, spas, the type of underwear. So a lot's been written about this. The type of underwear you wear sitting in hot spas have not been shown to significantly affect sperm quality. But we do recommend that if you are a man with a suboptimal sperm count, then having hot saunas or spas is probably not a good idea. Psychological stress profoundly affects sperm quality. It lowers your testosterone level, and a good testosterone level is essential for good quality sperm. And then the diet, fast food, ultra processed foods are not good. So basically, try and live a healthy lifestyle. Something about vaping. Smoking is not fashionable anymore. Vaping has taken over. There's also early evidence that vaping is really bad for your sperm quality. All right, so those are the lifestyle factors, and I think I'll move on to the microsurgical part now, which is when we deal with blockages. So the first bit, the varicocele, the lifestyle factors, those are all things that affect the quality of the sperm that is being produced. The blockages, on the other hand, you may have normal sperm that's being produced, but there is a blockage preventing them from getting to where they need to go. So it can either be a complete blockage where you have zero sperm, or a partial blockage where you just have a low sperm count or abnormal parameters. So obviously after a vasectomy, you will not have any sperm in your ejaculate, but other things like sexually transmitted infections, hernia surgery, and other infections can cause blockages in the tubes. So these are the sites where the tube can be blocked. Now, the normal route that sperm take, the normal transport route, is from the testicle into the epididymis. The epididymis is a thin tube. Then the sperm swim into the vas deferens. The vas deferens goes behind the bladder, through the prostate, into the bladder pipe, and the sperm eventually make it to the outside. And so blockages can occur anywhere along this pathway. If we look at a enlarged view of the testicle, so this is the testicle on the inside, you can see the meaty part of the testicle is actually made up of very fine tubes, and in these tubes is where the sperm is being produced. They swim through these channels and they enter the vas deferens and the epididymal tube, and they swim the rest of the way. So it's basically plumbing. It's tubes that can become blocked and need to be unblocked or fixed. These tubes are really small though, and that's where the challenge comes in. You can see this tube, the epididymal tube, is much less than 1 millimeter in thickness. And if I'm doing a reconstruction and reversing a vasectomy, for say, I need to basically work with this really thin tube, which is about 1/3 of a millimeter in thickness. Reversal of vasectomy previously did not have good success rates. We're talking 30, 40 years ago. Nowadays, with the microsurgical way of doing it and a very specific technique that's been around for probably 30 years, we're looking at much higher success rates. Realistically, if your vasectomy was 0 to 8 years ago, and these are my own data for about 300 cases, we're looking at about 87% surgical success rate. And even if your vasectomy was up to 16 years ago, we're looking at more than 80% success rate. Now, once again, it's really important for me that patients have realistic expectations about fertility treatment. And I spend a lot of time talking to my patients about, what can they expect? What are the realistic outcomes? These are the surgical success rates. So I can restore sperm and fix the tubes in a high percentage of these cases, but you still then need to make a baby afterwards. And that's where the female factors, female age, and those things come into play. So I realized very early in my career that it's not only about doing the surgery and fixing the blockage. It is about this journey of a couple where there's a male and a female. And you have to take all these factors into consideration when you talk about strategies and plans and treatments to make sure that for every couple you are choosing the right thing. I'll talk a little bit about genetic conditions now. These can get very complicated, and I am not going to spend much time on the detail of it, but I do want to say that genetic conditions that cause male infertility or subfertility are actually relatively common, and that's why we test for it regularly. If a man has a low sperm count of less than 5 million per milliliter, we should be doing at least 3 genetic tests. And I've seen this so many times where you've got a normal guy, grows up normally, good at sports, and then he gets a partner, they try and have a baby, they can't get pregnant, and then we start doing tests and we find out, well, you've got some genetic condition. And the most common ones are Klinefelter syndrome, microdeletions of the chromosomes, which are basically just small errors in some of the chromosomes, and the cystic fibrosis gene. Now, these men don't have cystic fibrosis, they don't have the lung disease that go with it, but they have the gene abnormality which can cause maldevelopment of the tubes. So we do these genetic tests relatively frequently, and every now and again we would find a positive. For genetic conditions often cause a total absence of sperm production, and that is probably the most challenging situation for me to deal with patients if they have a condition that affects their ability to actually produce any sperm. And we call this non-obstructive azoospermia, which means there is no sperm, but the cause is not a blockage. The cause is actually a factory, a production problem. And 25 years ago, the only option for such men would have been adoption or donor sperm. But microsurgery has changed all that. In 1999, a urologist in America did the first microdissection of a testicle, and he found that actually in about half of these men can we find sperm, and we can freeze it in the lab and it can be used and they can be biological fathers. And this is some of the surgeries I also do. Basically what we're doing is to, under a general anesthetic, open up the testicle, and I sit there for 2 hours and comb through the entire inside of the testicle. This is under microsurgical magnification, and trying to find a few tubes where there may be some sperm. Once again, we have to be realistic. Ballpark figure is about 50% of men we will be able to find sperm, but this depends greatly on their specific genetic condition and a few other things that we assess during the workup of this. This is where Repromed, the facility where I work, is really such a great partner to have, because they've got a world-class andrology laboratory on site. I have the absolute privilege of being able to perform these surgeries, and then I have a team of embryologists just literally in the room next door who take the samples and then spend hours under their microscopes looking and combing through it to find those few sperm that we need. I'll say just a little bit, we're almost at the end. I'll say a bit about unexplained fertility, and this is where a couple can't get pregnant, but we cannot find any specific male or female factors. I previously hinted at the fact that the basic semen analysis is not perfect. It is a good tool for us to use, but we know that about 15% of infertile men can actually have a normal sperm analysis result. And it's only on advanced sperm testing that we find where the problem lies. And sometimes we actually don't find any specific cause. There's just unexplained infertility. But DNA fragmentation is a relatively new concept, and these are often the men where the basic or the standard semen analysis is normal, but the quality of the DNA in the sperm head is actually the problem. And to assess that, you need to do very advanced testing. Now, the DNA material in the sperm head is essential to achieve a normal pregnancy. And we know if the DNA fragmentation is increased, and that basically just means there's damage to this DNA, then the ability of the sperm to fertilize the egg is decreased. And DNA fragmentation testing can now be done by most large fertility laboratories. It is a fairly expensive test still, and it needs to be added as an extra. And we don't do it just for every patient that walks through the door, but certainly those where we do not find other causes, they have recurrent pregnancy losses. These are the tests that we do. And there is quite a bit we can do about increased DNA fragmentation. Let me just see if my last slide. Yeah. So if you are diagnosed with low quality DNA in the sperm or increased DNA fragmentation, there's some supplements you can take. If an infection is causing it, we can treat it with antibiotics. A varicocele can cause it. We can fix that. You can change your lifestyle. Another easy one is short ejaculatory abstinence or frequent ejaculation. Now, there is this perception among some men that you should ejaculate less frequently in order to get a better sperm count, but we know without any doubt that storage of the sperm for too long in the body causes it to degrade, and it's better to ejaculate frequently. The sperm quality in those cases is often better. We can do sperm selection in the lab, and if all else fails, we can do a small procedure to actually extract sperm directly from the testicle where the DNA degrading has not taken place. So we are basically at the end. I can maybe just say that on my website, where the address is at the end, there's some resources on helping couples to achieve normal pregnancy. For me, that is still the ultimate aim, is to do what we can to allow couples the joy of the journey of having a child. So there's, apart from all the detailed surgeries and very complicated medical stuff, there's some very practical tips on how to time sex so that you give yourselves the best chance of pregnancy. About 2 years ago, we realized at Repromed that men are not getting the support, or it's difficult for men to tap into the support, the psychological support that they may actually need in getting a diagnosis of you are infertile or you are subfertile or you have a genetic condition. And we went through a process to see what help we can offer. There's some this Repro fact sheet that we compiled, and some links to support groups and just support for men who get diagnosed with infertility. I mentioned in the beginning, it's not something that guys talk about a lot, and we're obviously trying to change that stigma, but it is difficult, and I do realize it's a very personal matter for men. And that's basically the end of my talk. I hope I didn't go too fast, or I hope I didn't overload you with too much detail, and hopefully you gained something from this. Thank you.
Thank you so much, Dr. Zarrabi. We also have various information and previous webinars on our website, including topics around the timing of sex and different lifestyle factors and so on as well. That's more general to all genders. And I just think we've got some questions coming through. I think Kate's managing some of them at the moment. Kate, I sent some through to you. I hope that you have got them. So just bear with us a wee moment as we get them coming through.
I've got one here. I've got one that popped up on my feed. Should I go for it?
Great. Yes, please do.
Yeah. So question here, how do you manage psychological stress? Well, that is really important. What I recommend to my patients is to see a therapist. I see a therapist regularly. I think there is heaps of value in it. There are very practical and easy things you can do in your daily schedule to manage psychological stress. And I do absolutely appreciate that sometimes there are crises and really big things in life that pop up, which will cause stress that is difficult to manage. But there are very practical strategies that a therapist can help with. I find for me personally, exercise is probably the best way that I manage stress and try and live balanced. Yep, so that's what I would say.
Some great factors, some great advice there.
What is the management of high antibodies in the sperm? Now, this is, I think I got one slide actually that I added about antibodies. There we go. So I was kind of expecting a question about sperm antibodies because it always comes up. And this is specifically about sperm antibodies after vasectomy reversal, but I'll answer the question and say, what is the management of high antibodies in sperm? Previously, we used to think that you can take some steroids, the male, steroid medication. The evidence for that is not great. Nowadays, the best way to manage that is in the lab where they wash the sperm and select the sperm. I can say a lot of couples ask me after vasectomy reversal, will sperm antibodies, they read about antibodies, and once again, heaps of research has been done on it, and it's hardly ever an issue. But if you have a high antibody count on your semen analysis, then the lab sperm washing and sperm selection is the way to go.
I've got a couple of questions here just over from Facebook, but I'll just ask them to you. Are there any supplements or vitamins that have evidence behind them for improving sperm quality or count?
Am I allowed to say specific names of specific products here or not really?
Yeah, as long as it's sort of evidence-based.
Yeah.
And
I mean,
research.
This is completely based on how I practice. In each country, there is usually different supplements. Firstly, the evidence is not robust about supplements and antioxidants and the improvements. Most people would say if you are eating a balanced diet, then you probably don't need supplements. But there is evidence that some elements, zinc, for instance, can improve sperm health. There's a supplement in New Zealand called Menavit, which I often prescribe. And this is once again a discussion with patients. I tell them this is what it costs a month, and you can possibly benefit from it, but it is not guaranteed to fix things. Now, certainly, if you have a high DNA fragmentation index, then definitely a sperm antioxidant or a supplement is recommended. So I think the short answer is that in the right scenario, yes. If you have a poor sperm count, then a trial of 3 to 6 months of an antioxidant or a sperm supplement is a good idea. If you can afford it, it's not super expensive, it will not cause harm, and you will see within 6 months whether it made a difference. There's also the danger of taking too many supplements, and then you get not oxidative stress, but reductive stress, which is the opposite, where you are taking too many antioxidants, which actually damage the sperm. So don't overdo it. I sometimes see patients who have this whole list and they tick off every element. They take literally 5 or 6 supplements and antioxidants. Choose one that's balanced. As I say, I use many of it. There's others as well. And do a trial of 3 to 6 months.
Thank you.
I see on my feed what are the most common causes of male infertility and how are they diagnosed. I think we've covered this fairly extensively. And I'll just say again, it's mostly varicocele, lifestyle, and genetic causes are probably the most common ones. CoQ10 also beneficial for male plus the Minivit. Yep, I think there is benefit in taking both of them. Once again, you know, for us specialists, we are supposed to practice evidence-based medicine, which means that the treatment we give and the recommendations we make should be based on high-quality scientific research. To answer the question, is CoQ10 plus Minivit better than only the one or nothing? There isn't such strong evidence to support it, but my practice is to say yes, and a lot of fertility specialists will say there is probably benefit in taking CoQ10 with the Minivit. But if you only take the Minivit, that's also good.
How does age affect male fertility? Is there a biological clock for men?
Yeah, there is. So men still produce sperm well into their 70s, but the quality of the sperm does deteriorate. So the count, the morphology, what they look like. At the age of 34 is one of the gates where things do change. We also know that there seems to be a slightly increased risk of abnormalities in the babies, autism, for instance, as paternal age increases. But to give you a number, 34 is quoted as then you can have some deterioration in sperm quality. Not that I think it really affects practically anything that we do. I can get a fairly good idea of the sperm production function of the testicles by doing a few blood tests and doing an ultrasound scan. And if those are normal, one can expect there to be decent sperm production. It is, once again, not the perfect tool, but it does give us an idea. I think the bottom line is people in their 20s are way better at making babies than people in their 40s and 50s. I've got a question here. We're considering a sperm donor. What are the key things to think about when making that decision emotionally and medically? Unfortunately, I don't work much with sperm donation, but the couples that I do send in getting a sperm donor, the couples I do send in that direction are the ones where we have exhausted all the options and they are ready to move on. And I often find that if couples come to a point where they feel they have left no stone unturned, they have explored all the options that are available to them and affordable to them, then they can actually move on from that point and embrace the next step of that journey. But as I say, I don't really work that much with sperm donors.
One final question there.
I find it hard to explain male factor with my family and people from my background. What resources or websites do you recommend? I think, Lydia, you can maybe speak if Fertility New Zealand has anything specifically for males. I'll just say from Reprimed's side, we have that fact sheet, and on the back, there are a few links to specific support for men. There's not heaps. About 2 years ago, when we went through the process of compiling that, I made many inquiries, and it is limited, unfortunately, still for men. There's heaps for women, but I think in the landscape for men is still evolving. Lydia?
Thanks. Yeah, I agree. I was going to mention the resources you mentioned already about from Reprimed, but yeah, we have some on our website as well, not extensive, which is why this recording is going to be a great addition to our resources also. But feel free to reach out to our helpline and we can point you in the direction to some other sites and resources that we have access to as well. And anybody can access our helpline through info@fertilitynz.org.nz. And so, yeah, we're there to answer any questions or, give you access to other information as well. I think that's come to the end of the questions as well. Final chance if anybody's got any extras to pop in there. Well, thank you so much for sharing your time, expertise, and insight with us tonight. Male factor infertility is such an important and often under-discussed part of the fertility conversation, and we're incredibly grateful for your thoughtful and practical guidance this evening. And a big thank you as well to everyone who joined us this evening. We hope you found the session informative and reassuring wherever you are on your fertility journey. If you'd like to revisit tonight's webinar or share it with somebody else, the recording will be uploaded to our website later this week at fertilitynz.org.nz. And as always, we are here for you. If you've got any questions that come up after tonight's session or you'd like support at any stage, please don't hesitate to get in touch. You can reach us, as I mentioned, on our helpline by emailing info@fertilitynz.org.nz. We're here to help and you don't have to face this alone. As a charitable organisation, we rely on the generosity of our community. So if you're in a position, please donate and support us to support our community. Your contribution allows us to continue providing free information and support to people throughout Aotearoa. Before we finish, a quick reminder that just to let you know, our next webinar is on Tuesday, the 10th of June at 7:30 p.m. We'll be joined by Dr. Andrew Murray, Group Medical Director and Fertility Specialist at Fertility Associates in Wellington. Dr. Murray is a recognised leader in the field and known for his expertise and compassionate approach. The topic is IVF treatment and add-ons, and he'll be covering what add-ons are, how to evaluate whether they're right for you, and how evidence-based medicine can help you make informed decisions. Thank you so much, everybody, for being here this evening. Take care, and we hope to see you again soon. Ka kite.